Today I shall be talking about Ewing sarcoma. This is the highly malignant tumor occurring between the age of 10 to 20 years, sometimes up to 30 years. Talking about pathology, it commonly affects the long bones in 2/3 of the cases, femur and the tibia. In 1/3 of the cases, it affects the flat bones like pelvis and the calcaneum. It most commonly affects the diaphysis. On gross pathology, tumor characteristically involves a larger area and usually involves some whole medullary cavity. Tumor tissue is grey-white in color. It is soft and thin, almost like a pus. There is periosteal elevation with subperiosteal new bone formation, often in layers, and the tumor ruptures through the cortex and extends into the soft tissue. On histopathology, tumor comprises of sheets of uniform small cells resembling lymphocytes. Often, the tumor cells surround a central clear area forming a pseudorosette. Tumor cells have pale clear appearing cytoplasm due to presence of glycogen. Cytoplasm is periodic acid SCIF positive and diastase digestible as the cytoplasm contains glycogen. On clinical feature, it is most commonly in the age group of 10 to 20 years and range from 5 to 30 years. It is most common in the male and the patient presents with pain, swelling, and there may be history of trauma, and the patients have fever which can be confused with osteomyelitis. Sometimes the patient presents with pathological fracture. On signs, there is tenderness in the affected area and there is diaphyseal swelling and overlying skin is red with dilated veins. On investigation, we do the radiology, and in radiology, lytic lesion in medullary zone of mid shaft of the long bone is seen, and there is cortical destruction and cortex is destructs and new bone formation in layers which looks like onion peel. If it affects the flat bones, it is primarily a lytic lesion and there is no new bone formation. Like in long bones, in atypical presentation, mostly it affects the metaphysis rather than diaphysis, and there is only little cortical destruction and have predominantly soft tissue component which is confused with osteomyelitis. On biopsy, we can do the open or needle biopsy, and on biopsy we see the histology of the tissue section, and biopsy is the most definitive diagnosis. And we do screening for the monoclonal antibody to MIC2 gene encoded cell surface glycoprotein, which is specific to Ewing sarcoma and peripheral neuroectodermal tissue tumor like lymphoma and small cell carcinoma. Ewing sarcoma is the part of the family of the peripheral neuroectodermal tumor. This both has the chromosomal translocation in chromosome 11 and 22. But Ewing sarcoma is poorly differentiated. In Ewing sarcoma, there is a periodic acid SCIF positive and reticulin is negative, but in lymphoma, periodic acid SCIF is negative and reticulin is positive. And in blood we can check for the anemia, leukocytosis, increased LDH and increased ESR. In urine, there may be presence of vanillyl mandelic acid, and bone scan can be done for the bone metastasis. For the treatment, as Ewing sarcoma is highly radiosensitive, meds quickly on radiotherapy, but it recurs. So treatment consists of control of local tumor by radiotherapy, 6000 radiation, and control of metastasis by chemotherapy, and surgery like debulking of tumor or limb preservation surgery can be done. And for the chemotherapy, vincristine, cyclophosphamide, adriamycin is repeated every 3 to 4 weeks for about 12 to 18 cycles. And the differential diagnosis can be osteosarcoma, osteomyelitis, and other round cell tumors like reticulum cell sarcoma and metastatic neuroblastoma. This is all about Ewing sarcoma. Thank you.